second speaker for today is Dr. Nazim Ghouri. He's a consultant physician in diabetes, endocrinology, and general medicine at the Queen Elizabeth University Hospital and honorary clinical senior lecturer at the University of Glasgow. He has studied traditional Islam with Sheikh Rizwan Muhammad and Sheikh Amir Jamil, both in formal and in informal capacity for last 10 to 11 years now, and he has completed the whole syllabus in its entirety, mashallah. He's got particular interest in management of Muslim patients during Ramadan from a practical perspective, and he has authored and co-authored several papers in peer-reviewed journals. His main aim is to raise awareness, educate, and facilitate management of patients by drawing in relevant aspects from the Islamic sciences and involving scholars and leading clinical experts in their respective fields. He's also one of the two editors of the recently released, very novel, pioneering BIMA Ramadan Rapid Reviews Guidance. So we've got with us Dr. Nazim Ghouri. Over to you. Assalamu alaikum wa rahmatullah.
Okay, so inshallah, I'm going to make a start. So I'm going to kind of go through the BIMA guidance that has recently been released. And this is novel and pioneering in that no one has done anything like this before. So it is a learning curve for us, but we hope inshallah with the involvement of a number, I talk about a number, a large number of people in terms of people with an expertise from a clinical perspective, academic perspective, religious perspective, it will add some kind of credibility and weight to what has been done. So obviously my introduction was done. There's nothing else to add to that. I have no disclaimers either. So 1 second, if I can just get this too. There we go. So the synopsis for my session is largely go through what is the BIMA guidance, the origin or genesis of the guidance, and who is involved, how is it researched and prepared, some general principles, a bit on acute illness and some on chronic disease management, and also moving forward. And actually a lot of what Dr. Sheikh Dr. Rafaqat has mentioned has been touched upon in the guidance, not in as much detail because this is a more pragmatic clinical aid more than a religious aid, but the relevant aspects have been touched on. So the objective of these reviews, I've largely copied and pasted from the guidance, and I know that a lot of people won't have time to read the full guidance. I'm just picking the salient points. So I will somewhat read from the slides, but the idea is that I'm doing it now so you won't necessarily have to do that. And what comes to mind is the aim of this guidance is to synthesize existing literature on fasting with acute illness and common long-term conditions. Understand if there are any adverse or beneficial effects on patients observing Ramadan. This comes back to the point Sheikh Dr. Rafaqat mentioned in terms of having that kind of 60–70% probability, will there be harm or no harm, etc. But at the same time, we know that there is very little research in Ramadan, particularly out with the areas of diabetes and renal disease, for example. So in the absence of evidence, we wanted to get the views of experts from on terms of their recommendations related to various aspects of chronic diseases in various specialties, and get consensus, not only their opinion, but they had peer reviewers and contributors who then agreed with them. If they didn't agree, they had to reach a consensus. So the idea is that the hard work is being done because not everybody can access a respiratory physician, a cardiologist who not only understands the condition, but understands Ramadan as well, and is not just an isolated opinion. And the guidance is aimed at healthcare professionals to facilitate patient-centered decision relating to the embarking of safe fasting if fasting is undertaken. So it comes back to the concept of medical ethics in that every decision has to be made by the patient without duress, and they should have all the necessary information to do it. And as far as possible, shared decision-making is the ideal way forward. So what we're trying to do is provide information so patients can reach a decision which they feel comfortable with, but also healthcare professionals have a valid basis to provide. And as I said, the final decision rests with the clinician, with the patient. And at the same time, we're advising that they speak to the healthcare professional where they need further guidance, but also to religious authority, particularly when it might come to a situation where they should be fasting and there's potential risk, but there's about balancing the risk, or equally if being advised not to fast and they want a second opinion in terms of from the religious perspective. Because not every person who is a Muslim and a doctor is necessarily clued up with Sharia in terms of either a student of knowledge or a scholar or be familiar with access to either. And the opening section of the guidance is based on having some acute illness and sick day rule guidance, and with a bit of information on COVID-19 given the kind of general circumstances that we're in. And then we have the chronic disease section with common chronic conditions and how we should be managing them. Also, if there's any relevant COVID-19 specific information, we are touching upon that as appropriate. There's a bit on the immune system as well and risk of infection, because that generally affects all medical conditions and affects a lot of healthcare professionals in terms of the advice they give. And as far as possible, the knowledge given or shared by the contributors, allowing for valid ikhtilaf or scholarly different opinions compatible with Sharia. And I'll touch upon this later as well. And again, final point I want to make is the guidance is to be read as an informative recommendation rather than authoritative and prescriptive directives. Some of the work has already been published or is being published in peer-reviewed journals, so that adds credibility because it's been reviewed by our colleagues and esteemed members from our various communities in terms of clinical perspective. The hope is to get as much of this published as possible to add the credibility of the existing guidance. So why did this project come about? And the timing and the magnitude of COVID-19 was really what drove this project, because of anxieties that were arising amongst lay individuals and healthcare professionals in relation to Ramadan. And also some voices from other Muslim lands suggesting that there should be abstention for all given the current COVID-19 pandemic. Further, there is no current standardized or logical approach to guide healthcare professionals and patients when it comes to sick day rules and managing chronic diseases, with the exception of diabetes, which the various guidance which has been out there since early millennium, and renal disease more laterally. Consequently, we have patients, therefore, that can be in one camp who will fast regardless of their physical circumstances, and maybe patients in another camp who have very minimal or mild conditions who will not fast. So the idea is about striking that middle ground. And a quote from Dr. 𝐁𝐚𝐿, who's one of the contributors and reviewers of the guidance, and he's the current chair of the BBSI, the British Board of Scholars and Imams. This guidance fills a gap when it comes to getting advice when a patient cannot readily access an appropriate Muslim physician who understands the medical ailment at hand, as well as the importance and role of fasting during Ramadan in the life of a Muslim. And this was his comment when he was reviewing things when I got him involved with this. So I think this highlights the role and niche that this gap fills. So who actually is involved? So we've got 65 or so healthcare professionals and clinical academics in the form of editors and our contributors and peer reviewers. All of them have an interest or experience in the management of patients in Ramadan. And some are actually experts in this area, or at least experts in their specialty. When I talk about experts, these are not only national, but also at international level. And there's also scholarly involvement, approval, and there's also student knowledge involvement in terms of the background of some of us. And like I said, we've got the formal support of BBSI, and 𝐁𝐿 is a formal contributor to this and has written part of the general principles. So who's involved? So I've obviously mentioned like the different roles that people have been contributing, but in terms of who are the names of these people, just to kind of get some familiarity and reassurance, and also perhaps give you an opportunity to understand the types of people that are involved with this, so that in the future, if people wish to get involved or wish further information or to contribute in terms of particularly contribute to objective research to help shape opinions into kind of more factual statements, this would help. So we've got Dr. Salman Waqar, who's an academic GP at the University of Oxford. He's a General Secretary for BIMA. He's the one who conceived the original idea and really the engine behind the project, kind of driving people and making sure people were doing their bits and ensuring that it was up to standard. I'm the other co-editor of this. You know my affiliations from the start. I've got a background of studying traditional Islam with my teachers, formally and informally. And I think perhaps what I can lend is that I have experience and expertise in the care of Muslim patients, particularly in relation to diabetes, but also general medical issues. I've written several papers. I've got ongoing projects in peer-reviewed medical literature. And this is valuable because it's important that when you do publish something that it's recognized in peer-reviewed literature for two reasons. One, it gets familiarity amongst your colleagues, and it shows that we have a kind of methodology and we have a professional element to the information we share. But also when it comes to referencing work in future, when you want to go back to sources, not everybody can access the Hashaf ibn Abidin and all these other texts that people refer to. So this helps bring some of these traditional texts into the contemporary medical literature and makes it easier for referencing as well. In terms of some of the contributors, in fact, these are all the contributors for the general and the section specific. I've put all their names there. I don't expect you to necessarily read and know everybody, but the idea is to highlight the diversity in terms of throughout the UK, but also the level of expertise. I mean, some people will have heard of these names from other non-Islamic aspects of medical practice and academia. Professor 𝐁𝐚𝐿𝐴 and Professor of Endocrinology in London. I think anybody who knows is in the field of endocrinology or diabetes or knows London will know Professor 𝐁𝐚𝐴. Professor Naveed Sattar, who is my supervisor for my MD, who is pretty much a world authority when it comes to a number of metabolic and cardiovascular risk factor aspects. Also has been a co-author with several of my papers relating to various Muslim matters. We've got Sheikh Asim Yusuf, as I mentioned, who's the chair of the BBSI, and he's a consultant psychiatrist as well. So he provides some important and useful guidance in terms of capacity and how that fits in. And we've got various other colleagues from all the different specialties throughout the UK, some in very recognized and reputable institutes in London, Oxford, and the like, and other people who are very esteemed in their own fields and certainly making a name for themselves as they go through their specialist training. We've got Dr. Ida Jawhari from Nottingham, who had got around 10 people to peer review her section related to gastroenterology. Again, a very thorough section there. We have our very own Dr. Arshad Latif, who has contributed to this, and this is the list of contributors there. And some of the peer reviewers that we've got who reviewed the various sections, we've got people again from all over the UK, from recognized units as well. We've even got Professor John McMurray, who is probably the authority when it comes to heart failure at a world level, certainly at a European level, who helped provide some information regarding heart failure and fasting. And again, this is through the networking. The more people you have involved, it's easier to network and get people on board. Again, when it comes to specialties, you can see there's several names to each specialty, and I haven't put all the specialties, but it gives you an idea in terms of how robust it is in terms of consensus. So that's a lot of work, but how did this all come out? What's the methodology behind it? Because the methodology gives the credibility to the work. We aim to provide a summary of the current literature using narrative synthesis and expert statements. There is no standard methodology for rapid reviews, but we utilize principles outlined by the Cochrane Collaborative Rapid Reviews Interim Guidance from 2020. We used PubMed and Google Scholar between a couple of dates in March to search for things, and we did parallel searches in all the different specialist areas. And we use various terms. You can see Ramadan along with relevant specialty, and we've listed the search criteria in each of the sections. There was screening of the various papers, but we also use literature reviews to help get further references and to broaden our net to capture as much of the data as possible. Although there's no language restriction, we used the review of English papers for obvious reasons. And within each review, we haven't got all the conditions for each specialty, but the ones that we were able to provide useful information on and the common ones. And as I said, the most important thing from this is each of the sections, even the general principle sections, has consensus. And it comes from people who have an understanding of Ramadan, looking after Muslim patients in general, but also during Ramadan. We were given expertise on gathering expert opinion through Healthcare Improvement Scotland. So again, we're trying to make use of all the existing standard bodies that we have out there to make it as credible and as thorough as possible. If there were differences of opinion and disagreements in various sections, we tried to get people to come to common ground on things to make it easier for people. I certainly remember this when, although not a psychiatrist, I reviewed every section with Salman in terms of some of the issues that were there and seeing that discussion. And alhamdulillah, what it does is it leads to people understanding and appreciating the nuances and to come up with pragmatic guidance. And as I said, finally, where possible, we've tried to get some COVID-19 specific guidance if relevant and appropriate, and if possible, supported by evidence, which at present is very minimal. And I think the final thing that adds uniqueness to, and which was very much what I wanted to see, was we have used the Diabetes and Ramadan Alliance traffic light system in terms of risk stratification, in terms of categorizing people into the red or very high risk, and I'll show a picture of this later, the kind of amber and high risk, and then the green is low moderate risk in terms of whether they should be fasting or not fasting. And the reason I wanted to use this is something that is established from the diabetes land. And also it has been approved by the Islamic Organization for Medical Sciences, International Islamic Fiqh Academy. So it has a recognition amongst scholars in terms of something that's familiar. And the final thing I just want to put is a formal disclaimer we have put in that whilst the work has been peer reviewed, it's not been through a formal consultation process. And it's not authoritative or prescriptive, but is informative. And one thing I will say is that there are a number of these areas which have had peer-reviewed publications, but not all of them have. In the process of trying to get that, as I said, and this again helps add to credibility, because not only is this literature being reviewed by more and more people, but it's being reviewed by people who actually understand the various subspecialty areas as well. So I want to give you a flavor of this guidance. I'm not going to go through the whole table and every single condition and everything, because it's there to be as a reference guide, and I use it as a reference guide. Even though as one of the editors, I have to go back and check things because it just shows that we don't know everything. So there's some general principles at the very start, giving some reassurances for those that are healthy, advice on looking after oneself and adhering to government guidance in light of COVID-19. The importance of discussing any change in medication with their GP or specialist prior to fasting, because nobody should be making isolated or unilateral decisions in terms of medication changes. And they shouldn't hesitate or delay in seeking this guidance, but also if they become unwell or their health is improving, again, seeking medical advice and help as appropriate. Guidance on mental capacity, implications and obligations depending on the extent of impairment. Basically, are people going to a state where the obligation is lifted from the outset, and therefore they're in essence like a child, and therefore there's no obligation, no fidya, etc. And again, 𝐁 Hassan Yusuf has contributed to this. Some precautionary advice in light of COVID-19, and we've touched a bit more in detail in acute illness, which I'll cover next. There's some specific comment regarding frailty and obesity and ethnicity with regard to COVID-19 because of the higher risk groups. There's stuff on PPE as well, taking on board some of the opinions that are there from a religious perspective. Again, none of the opinions here are our own. We're quoting and referencing to the ulama as appropriate. And also acknowledging potential matters of ikhtilaf and not neglecting the spiritual dimension of Ramadan and advising patients. And this builds on the point that Sheikh Dr. Rafaqat mentioned in terms of what to do when there's not a Muslim doctor, or is this Muslim doctor classed as, in inverted commas, someone who is practicing or whatever it may be. And we acknowledge that in the traditional books of fiqh, there is reference to a Muslim doctor understand the condition and that being Muslim and so on. But again, it comes back to that point that Sheikh Hassan Yusuf mentioned, is that not everybody can access a doctor who is Muslim, who is not only Muslim but practicing, but also understands the specific clinical decision that needs to be made or the ailment at hand. We are doctors, but we don't know everything. So the idea is by having this guidance, we're providing a starting point for discussion. By having the hard work has been done, this guide helps people then take this forward. Ultimately, its use is at clinical discretion and the decision is the patient's, but we're providing enough evidence and information hopefully to at least start that discussion. Again, when it comes to acute illness, the same theme applies. The ultimate decision to fast or not rests with the patient. If there are symptoms suggestive of COVID-19, namely fever, malaise, and persistent cough, we advocate terminating the fast or abstaining from fasting and ensure adequate hydration, seek timely medical advice. We might be going on more a cautious side than ordinarily one with other illnesses, but because we're learning about disease and because of the increased risk associated with people, with individuals from Black and minority ethnic background, of which most Muslims are in the UK, we have to we've taken a very low threshold to giving this kind of advice of breaking the fast. Like I said, it is the patient's individual choice, but from a medical perspective, we have a responsibility to do no harm first and foremost, and that's why we've taken this. If someone becomes acutely unwell with non-COVID symptoms that create hardship with continued fasting or struggle to keep the fast, patients are given advice based on a flow diagram that we have. And again, draws on what Dr. Sheikh Rafaqat has mentioned, obviously not going into as much detail, but allows those principles to manifest. So we have the left arm, which is the COVID arm, and we have the right arm, which is the non-COVID arm. And I think the COVID arm is fairly self-explanatory. The non-COVID arm, again, draws on what Sheikh had said, and in terms of using that concept of ghalabatul dhann and prior experience, or using the opinion of an appropriate clinician, the prior experience of fasting such an illness or ailment, and common knowledge. So common knowledge, for example, would be that we know that if somebody has an infection, is taking antibiotics 3 times a day, and they have to take that antibiotic 3 times a day because there's no other alternative or it's the most appropriate, then obviously by fasting 18-20 hours, you're not going to take your medication, your antibiotic 3 times a day. We know as a result of that, it's either going to be delayed healing or your illness might worsen and antibiotic resistance, so on, force might come through. So that's an example of that. Prior experience of fasting is such an illness. So if somebody has an ailment and they know that by fasting that ailment gets worse, I'm not going to list them, that would be the type of evidence that we'd be advising people to refer to. And again, at any point in time, if there's any concern or issue, they should speak to a doctor and or religious authority. Again, when it comes to chronic disease management, again, we've got a 2-step process instead of having a flow diagram or figure which can be used to help ascertain whether somebody should be fasting or not. Again, drawing on what Dr. Sheikh Rafaqat in essence has talked about, but applying to a clinical perspective. As I said, we've got the 2 higher tiers, a very high risk and high risk category. And the general advice would be that they shouldn't be fasting or must not fast depending on the severity of it. But at the same time, understanding they may have fasted before with the ailment, but also the fact that they can maybe fast in the winter when the risk category may be downgraded because just the fact the duration of fast is less, that allows medication to be taken at appropriate intervals, or there might not be as much physiological compromise put on the body. Those with lower moderate risk, again, it's not a blanket thing that they should just fast. They should speak to their doctor about it as well, especially when they have multiple morbidities and the risk might actually go up. Again, if medication is twice a day or 3 times a day, depending on that aspect of things. And the judgments are based on clinical risk, which is at the discretion of the advising clinician. And I accept that there will be there can be difference in scholarly opinion, there can be difference in clinical opinion as well. But what we say is that clinician making a decision, hopefully by using this tool, has some basis to start the discussion and either to follow or diverge from it. And as far as possible, it's a shared decision-making process. In terms of the diseases that are covered, it's not an exhaustive list of conditions that we've covered based on expertise we have at hand, but the common ones are there: cardiovascular disease, respiratory disease, chronic kidney disease, gastroenterological disease, diabetes, adrenal disease, obesity, neurological disease, a bit on pregnancy, a bit on hematological disease, cancer as well, rheumatological disease, and mental health. So in terms of this figure that we use as a decision-making tool for the chronic diseases, does the patient intend to fast or not? Is the first question. If yes, then we risk stratify based on table 1. I give special consideration to the patient's age, frailty, previous experience of fasting, and if you have more than one comorbidity, where the risk may be compounded. And then based on that, we have the traffic light: very high risk, and low and moderate risk. If they're still choosing to fast in the first 2 categories, again, we're advising them to seek the opinion of trust of a religious authority to discuss their exemptions from fasting if they're worried that they might be committing a sin, or there might be some kind of guilt, or they might be displeasing their Lord, or whatever it may be. Again, if somebody's that high risk category, again, we are advising that there should be caution involved, explore their previous experience of fasting, because maybe, yes, we can work with it. We're not against people fasting. It's about safe fasting and not putting themselves at risk, not putting their family members and giving them undue stress because they're worried about all the time. And also understanding that obviously we have to be able to access healthcare and be able to get the necessary advice and input in a timely manner. And again, there's a blue box at the bottom that states that in all situations, patients should be aware that advancing age, frailty, obesity, and comorbidity are associated with worse outcomes with COVID-19 illness. Consider upgrading risk based on clinical discretion and or where multiple comorbidities exist. Also discuss deferring fast until shorter winter months for patients where medication regimens may not be suitably altered, or there might be a severe dehydration risk. Continuing to fast with COVID-19 illness may be detrimental to health and a sign of significant risk to life. So again, we're trying to draw that middle line. In terms of the table itself, I'm not going to go through the whole table, but I'm showing the top aspect of the table and the bottom aspect. So the top aspect has this some general guidance on the condition itself. In terms of like if patients have conditions that fall into either of these 2 high-risk categories, maybe going through some of these checklists. And if they still insist on fasting and we've tried our best to support them, they should be prepared to break the fast or abstain from fasting in case of adverse events. And I think this is the most important thing, because the point is about doing no harm, both from a religious perspective, but also from a medical ethics perspective. I've just used respiratory disease because this is the condition that comes first in the table, but to give an example of how we have stratified conditions into each of these three areas. And as you can see, a lot of common sense will prevail, but also at the same time, where the specialists know the condition and have been able to put a condition in a particular category based on their expertise. And again, for example, those receiving immunosuppressants for active lung disease, we've put them in a high risk category and advised not to fast because again, their immune system is being down-regulated. Some of the symptoms might be masked in terms of acute illness as well. And obviously these drugs have to have levels and certain ranges and things. So again, we're trying to minimize the adverse side effects from these treatments as well. At the same time, for example, low, moderate risk, and we've used the example of well-controlled asthma COPD requiring intermittent inhaler use only, or stable disease with infrequent exacerbations, or those receiving immunosuppressants for stable disease, for example. So we have a common sense approach to it all. And again, just highlighting that table there. At the bottom of the table, we have some notes, again, to help guide the healthcare professionals when using it, explain that this is not an exhaustive list and should be used for informative and shared decision making. If the condition is not in the table and they have uncertainty about fasting, they should seek medical advice before doing so in terms of the patient should be. And if this is not possible and they decide to fast, the advice should be given regarding terminating the fast and followed. Also recognizing as well that for some patients, there might be a permanent or perpetual state of affairs where somebody shouldn't be fasting. Again, that's where the fidya comes into play, and we advise that they should speak to a religious authority before doing so if they want further clarification on the matter. And when it comes to breastfeeding and things, we've made reference to the MCB Ramadan health fact sheet, which I was fortunate to review and contribute to prior to it coming out this year. There's some conditions, for example, which have been upgraded because of COVID-19 from perhaps a lower moderate risk to a high risk, or from a high risk to a very high risk. And that's highlighted in point 7, sorry, not point 7, the asterisk, expert recommended upgrading of risk due to COVID-19, recommendations subject to review if relevant evidence suggests regrading. And I'll just switch my screen very quickly to give you an example of that. One second. So if I get the Ramadan review guidance here, oops. So conditions marked with an asterisk actually come into, I think, adrenal disease, for example. So we've put somebody who's on aldosterone deficiency on fludrocortisone or mineralocorticoid replacement, as well as on glucocorticoid replacement. We have moved them to a higher risk category for the purpose of COVID-19 because dehydration and secondary to malaise or fever is quite real. And whilst our general existing guidance, which inshallah will be published, has been accepted by clinical endocrinology, we have people in a lower moderate risk category upgrade to a high risk category just because it's already very tricky with sick day rules, and we have upgraded accordingly. But like I said, if the evidence suggests that there's no risk, we can downgrade as appropriate. Coming back to the slides. So I want to actually just touch upon a couple of things. Actually, I'll come back here to what Dr. Sheikh Rashid mentioned in relation to this concept of interplay between Sharia and secular law when it comes to various aspects of a person's day-to-day life and their working, and will that impinge their fast, or will the fast impinge their ability to work, and so on. And I had done a paper with Sheikh Rizwan Muhammad and a few of my diabetes colleagues related to driving and fasting, because driving has certain medical legal implications. If a blood sugar is under 5, one should not be driving. If they're on insulin, they have to raise their sugars. Likewise, if they're under 4, regardless of insulin or sulfonylurea, they would have to break the fast and not drive until sugars are over 5. So there's a legal aspect of things there. So again, it comes back to the aspect of driving a person's life in terms of, is it needed for them to do their job, or the propensity for hypos, etc. So again, it's a lovely paper to read because it helps understand this interplay between Sharia and secular law, but also within it, there's also a flow diagram in terms of having that discussion with the patient and how to risk stratify patient and exploring options and mitigating risk and trying to optimize therapy. And final thing as well within this is reference to sacred, to traditional texts as well. So for example, the concept of a recurring situation where a person is breaking their fast because the circumstances are replicating and need to work and then abstaining from future fasts. So it's quite good, and it helps understand the concept of hardship as well, because there isn't a recognition that there should be a degree of hardship, but to what extent, as Dr. Sheikh Rafakat mentioned. So in terms of the responses so far from the guidance, it's been very favorable, alhamdulillah, particularly from our non-Muslim clinicians and academics. And this is very important because not everybody lives in Bradford or in Birmingham or Leicester where they can access a Muslim physician, either in their specialty or their GP. So if having your non-Muslim colleagues on board and supportive of it is very important, because I said that bridges the gap that we talked about earlier. Defined the guidance as a valuable and important starting point for consultation. There's also already formal endorsement from the British Thoracic Society, and at the moment it's under review for endorsement by the Royal College of Physicians London, and it's a very welcome piece of work based on the response received so far, and certainly some of the specialties have said to formally endorse, other specialties are taking a bit of time going through it. But the pleasing thing so far is that there's been formal signposting by various CCGs in England. The Royal College of Physicians, the Royal College of General Practitioners have formally signposted it. The Association of British Clinical Diabetologists have formally signposted it. The Renal Association have, British Gastroenterology Society, and NHS Scotland Library. And the guidance is always being revised and edited as the need arises, and we're on version 1.3, and we have a change log as well so people can track the changes that are there. They're very subtle, but we are in a dynamic situation and circumstance. For example, a few papers have been submitted and have been accepted for publication, alhamdulillah, relating to this, particularly to do with clinical guidance in societal and authoritative and high impact journals. In terms of the future, my aim, and certainly the aim of all the contributors, is to get this guidance formally recognized and supported or endorsed by key clinical bodies such as the Royal College of Physicians and the Royal College of General Practitioners, because then this means that we have a standard of care for Muslim patients that is not only widespread but also is considered safe and clinically appropriate. To enhance and publish as many of the sections as possible in peer-reviewed literature, particularly in the societal high impact medical journals, several are published and accepted and several in preparation or under review. To undertake clinical studies as a result of this guidance, so we can qualify opinion or support opinion or even refute opinion with evidence, because that's that concept of Dr. Rafakat mentioned, that 60-70% moving closer to 100%. And to consolidate on a collaborative approach between the scholars and HCPs, and certainly the involvement of BBSI working with us and hand in hand. And to be honest, it's been a fascinating experience for me, because whilst I've worked with some scholars in the past, but to get the formal support and the collaborative work shows that we can harness the expertise and knowledge in both camps. So just to conclude, this new guidance is obviously novel and pioneering in an attempt to standardize the patient management in Ramadan, to make things easier and safe, and importantly Sharia compliant for all parties concerned. As experience and evidence base grows, the guidance will refine, consolidate and update as appropriate. It's not prescriptive and authoritative, and this is very important, but it's recognized that bodies, religious and clinical, are signposting and endorsing. So the BBSI have formally signposted to this guidance and supported it because they have their contribution as well. And this does not replace clinical judgment or patient choice. And where needed or appropriate, the discussion with the religious authority is always encouraged. I just want to give some acknowledgements in that Dr. Salman Wakar, who's the kind of lead and co-editor in this, Dr. Arshad Latif, who's been involved with it, Dr. Sheikh Asim Yusuf on behalf of BBSI, Dr. Ahmad Mahmood, all the contributors and peer reviewers, the pages and pages of that, and my teacher, Sheikh Razwan Muhammad and Sheikh Amr Jamil, may Allah have mercy upon them all. So I'm going to stop my screen share there.